Very good morning, everyone. Thank you for being here. And we will begin the IC270, that is Managing Complex and Complications of Cataract Surgery. So before we move on to the instruction course per se, we have a very special keynote address by Dr. Ashok Kumar Nanda, who will be speaking about how we prevent posterior capsular rent.
Thank you, Piyush, and good morning, everybody. Though we are going into discussion of complications or complicated cases in cataract surgery, I would be talking something preventive, which is good to know about how to prevent PC rent. We all know PC rent is something which you do not want. It's an unwanted guest. And so we have to know about the risk factors of list of risk factors which can actually cause PC rent so that we can prevent. It's not moving, yeah. So PC rent is something which is either pre-existent or can be a surgical complication, and as a surgical complication, it has an incidence of incidence of about 1 to 4%. Why it's going on its own? I'm not doing anything.
Can somebody from audio visual please help out? So it's moving ahead without his moving the cursor, and it's also
go back one slide, please.
The ratio is also not correct. Abhi ho gaya.
Okay, one slide. पीछे जाओ भी हाँ. So there are पीछे जाओ पीछे आगे जा रहे हो आप. और एक. Yeah. So the incidence of PC rent during surgery varies from 1 to 4% and depends on various factors which we will be enumerating. The patients who undergo cataract surgery, if they have a PC rent, there is a 30% probability of having a complicated post-operative recovery with incidence of post-operative inflammation, cystoid macular edema, retinal detachment, increased hyphema, cortex retention, and secondary glaucomas, corneal edemas are pretty high. Placement of a IOL, especially in a toric lens, is a real challenge. So it's better to prevent and understand what are the predisposing factors. We divide the predisposing factors into 4 categories: equipment related, patient related, eye related, and surgeon related. So in the equipment related, it can be a microscope or phaco machine going faulty. Patient can be prominent eyebrows, deep set eyes, narrow palpebral fissure, spine problems. Eye related could be corneal, antechamber, or iris and lens related, and surgeon factors, of course. So a patient with increased age, having back problems, too much of anxiety, breathing issues because of COPD, all these increase risk of PC rent. Inadvertent head movements due to Parkinson's, Huntington's chorea are also high-risk patients. Deep set eyes cause pooling of irrigation fluid and causes reflections, reducing visibility, and exaggerated Bell phenomenon causes jerky movement of the eye. Visibility issues can be due to corneal scar, corneal dystrophy, spheroidal degeneration, pterygium covering the pupillary area, band keratopathy, and so on. Cataracts can cause PC rent, especially if there are intimation cataracts, black cataracts, posterpolar cataracts, or cataracts associated with trauma or lentiginous and lentiglobus. These are high-risk cases. Pseudo-exfoliation per se is a high-risk surgery where you have a chance of jugular dehiscence and PC rent. Small pupil is one of the most common cause of PCR due to senility, eye phase, post-synechiae, long-term use of topical pilocarpine, pseudo-exfoliation, and diabetes. So there is little visibility issue and PC rent. Shallow antechamber due to phacomorphic glaucoma or anti-angle closure glaucoma. It leads to doing phaco in a very shallow chamber, leading to PC rent. And deep antechamber due to high myopia causes general laxity, lack of scleral rigidity, and trampoliting effect of the posterior capsule. Pars plana vitrectomy causes lack of vitreous support and lens touch. So machine related, if you are not familiar with the phaco machine that you are handling, and if there is a sudden surge, if there is a collapse due to irrigating line getting blocked or bottle finishing midway, then there's a risk also. Faulty setting in the microscope where the brightness is poor, coaxial illumination is incorrect, focus is not proper, or there's a fogging below the eyepiece, then that case there's a high risk. Surgeon-related factors could be lack of experience, fatigue. See, when there's a long list of surgeries, this surgeon, who is me, of course, is trying to do a posteropolar cataract and trying to aspirate out in with a phaco tip, which is bad, and you are likely to, of course, I escaped here, but you are likely to have PCR in these cases. To begin with, prevention is a good preoperative evaluation and starts with history taking. Ocular trauma history is a must. Ask for previous surgical procedures like pars plana vitrectomy. Examination of the fellow eye is very important because if the previous eye has been operated, and look for complications, whether the previous eye had any complications. Always prefer a peribulbar anesthesia than a topical in high-risk cases, and of course, general anesthesia or sedation is necessary. Reduce IOP whenever you feel that there is a risk by giving mannitol. Intraoperative visibility should be, as I mentioned, microscope should be good with good coaxial illumination. Speculum use you must remember that the size of the speculum and the weight of the speculum should be taken into consideration. Too tight speculum can increase the upthrust of vitreous, leading to PC rent. Wound construction has to be done done properly because vitreous is a good culture medium, so it has to be a good sealing wound. Too small wound causes wound burn, and too big wound causes chamber instability due to wound leak. Pupil dilatation should be done either with some pupillary expanding devices, iris hooks. If there is synechia, it has to be released. Rhexis, a complete rhexis is essential. Aim to have a bigger rhexis. Keep a micro scissor ready if in case you are dealing with a hypermature cataract with a anterocapsular plaque. Hydrodissection has to be gentle. Remove antechamber, some of the OVD from the antechamber before hydrodissection. Inject small amounts. Tap the nucleus gently in between so that you prevent capsular block syndrome. It is quite likely to have a PC rent when you are trenching in a soft cataract because the posterior capsule comes off very easily. Be careful. Even in a hard cataract, the sharp edges of the pieces can cause PC rent. Posteropolar cataract, no doubt, is something one has to be very careful. Anyway, I'll skip the video for lack of time. While doing irrigation aspiration, avoid tilting the irrigation port to the down to polish the capsule. So in case it catches the posterior capsule, you have the converging folds on the tip, towards the tip of the irrigating port, and it's called a spider sign. If you have a spider sign, immediately stop and reflux and release the capsule. While inserting IOL, when you do it with a hydrophobic lens, especially in a cold condition, there is a possibility of sudden jerky release of the IOL, and that is one of the important reasons. So it has to be a gentle injection of IOL, especially in cold areas. The injectors have to be checked. Sometimes it is also tight, and when you push, it goes with a jerk. This is a hydrophilic lens where it's a plate haptic lens. It was loaded improperly, so while coming out, it reversed and flipped upside down, causing a PC rent. So to conclude, identify the presence of predisposing factors, make appropriate modifications of your surgical plan, and mitigate the risk factors to prevent PCR. In case there is a PCR, identify early and manage. Do not panic. Thank you.
Wonderful, sir, for this lucid presentation. There were so many points that you covered. Maybe for a younger surgeon, if you can say your top 3 pearls of how they can avoid a PCR, just the top 3.
Good visibility. Never compromise or continue surgery if you are not seeing well. Any step that you are seeing should be visible to you. Number 2, try to achieve dilatation properly. That is very important. And number 3, which I feel is your most of the times your irrigation aspiration is the step where there is a little higher risk of PC rent. So that has to be gentle. More PC rents I have found in my fellows happening during doing irrigation aspiration. One has to be gentle about that.
Thank you. Thank you, sir. So we'll probably have to change the order a little bit. And can I invite Dr. Somil Sheth to present his talk on nucleus drop? Dr. Somil is, of course, have you loaded your presentation?
So my presentation is about dropping the bomb. Whenever you don't follow what Dr. Ashok just mentioned and you land up with a PC rent and a nucleus drop, how to manage that? I'm going to be presenting a lot of unusual cases about managing nucleus drop. And I would say it takes a lot of courage for so many people to turn up on a Sunday morning at 8 o'clock after having partied Saturday night. So thank you for the audience. Now this is a case that was referred to me by an anterior segment surgeon saying, I have done everything. All you need to do is anterior vitrectomy and put in the lens. There is no capsular support, so I did exactly that. I put an iris claw lens, posterior or retrofixation behind the iris, and it's got done well. Now when I was trying to do that anterior vitrectomy, I just took a peek inside and this is what I noticed. The anterior surgeon will never tell you that he's dropped a piece or two. Now how do you remove that piece despite the iris claw being there? So what you do is I impaled it in a 26 gauge needle, and between the pupillary border and the border of the iris claw lens, I tried to bring it out into the anterior chamber. I could have taken a fragmentome and done it inside the vitreous, but then I would have had to take a suture. The patient was told, by sutureless, you have to do it. So this is what I did. And the advantage of doing this maneuver is that you have a scaffold of iris claw lens, and now you can phaco very well in the anterior chamber without the risk of any piece dropping into the vitreous cavity. You see there are so many fragments that come into the anterior chamber. They move around in the anterior chamber and they don't drop into the vitreous cavity. So you can perform your phaco very successfully as like how you would have a posterior capsule in the first place. And so the phaco is done, and then you're left with no lens matter in the vitreous and the surgery is done. In this case, I'll just pause here. The surgeon has dropped both the nucleus as well as the IOL. Now what does common sense tell you? That yes, you need to manage the nucleus first and then lift the IOL. I did exactly the opposite. I lifted the IOL first. Why did I do that? Because I learned from my previous example. I removed this IOL out into the anterior chamber and then retrofixated it behind the iris in the same way as I did in the previous case. So I put an iris claw there and I knew very well how to manage the nucleus like what I did in the previous case. I impaled it with I took it away from the macula, impaled it so that there is no pressure on the macula of the nucleus, and exactly this is what I did. I took it out between the iris claw border and the pupillary border into the anterior chamber. There were a couple of small fragments of the cortical matter that has got dislocated into the vitreous, but that you can easily manage with a cutter. You don't need really a fragmentome. This is where you would have used a fragmentome otherwise. Here you use a normal phaco probe, and the other pieces can easily be managed. These are just epinuclear or cortical remnants which would have easily come off with the cutter. So this is one of the ways by which you can manage a nucleus drop if you have an IOL scaffold by not actually going with a fragmentome into the vitreous. Now this case, just look at this case. This is a case of a multifocal lens. The surgeon has implanted into the sulcus and the lens is decentered. And there is a lot of cortex behind. This patient, despite having multifocality, is not going to see well because first of all, the lens is decentered. Secondly, the lens is in the sulcus. The patient is going to have a major refractive error. So in this case, the way you manage this is, yes, obviously you need to go behind and remove the cortical matter, but that would only tackle the anterior vitreous and the cortical matter. What do you really do of the IOL? Should you explant it and then put a 3-piece lens in the sulcus? So what I noticed is that there is a PC rent which is right across, and there is enough of capsular support for me to go. So what I did is this is a maneuver again that I do, which is not very commonly done. Put a light pipe and check the vitreous cavity. This light pipe is put from the anterior port, not from a pars plana port. And then I try to put the lens in between the anterior and the posterior capsule. And this you have to do in a bimanual way. You cannot just put it easily. You have to lift the anterior capsule with one instrument, and with a forceps, the intravitreal forceps that we commonly use, you put it in between the capsule. And that's how you get the lens in the bag. I don't know why this video just stopped. So I'll probably see so there it goes into the bag. You see a crumpled bit of the posterior capsule here, and it falls back in place, comes when the lens is nicely settled into the bag. I'll go on to the next case. This was a case that I presented previously. And this is a little bit of outside the box kind of a thinking. Now you see this is an open and shut case. The surgeon has actually put the lens in the sulcus and has referred the patient to me to manage the cortical matter behind the lens. All you need to do is just a little bit of anterior vitrectomy, do away with the cortex, and that's it, open and shut case. Now why am I actually presenting this despite it being so is because let's say I started doing anterior vitrectomy here, and when I was doing anterior vitrectomy, as the vitreous started clearing and the view started becoming better, I realized that it was not a PC rent. It was actually a zonular dialysis from this clock cover to this clock cover, and the bag was fully intact. So the cortex was not actually in the vitreous; it was in the bag per se. So I really don't need to do a vitrectomy. So what I did is first inflated the bag with viscoelastic, and this is a little bit of acrobatics that I did. Put in a CTR behind the IOL into the capsular bag and inflated the bag. And once the bag is inflated and all the vitreous is pushed behind, I don't really need to do a vitrectomy. Though I took a vitrectomy probe, I just went behind the IOL, put in an AC maintainer first, and just aspirated the lens matter without cutting it. The bevel is facing me, it is not facing down. Otherwise, it would now create an iatrogenic posterior capsular end. Now, having done that, the lens is very well sitting in the sulcus, but I now needn't put it in the sulcus at all. I can actually put it inside the bag, and that is what I did. And that is how this was managed. The patient didn't have to undergo IOL explantation with a 3-piece implantation. I could manage with a 1-piece lens because I put it actually in the bag. Now this is not all. You can get away with doing this. You don't really need to stop at this. Despite having just a zonular dialysis, no vitreous in the anterior chamber, I still went posteriorly to complete my vitrectomy. And this is the reason why. Because if you have a PVD that is induced by an eventful cataract surgery, this is what you would have landed up in the late postoperative phase. You would have had an iatrogenic break. You see a break actually developing when I'm trying to tackle the vitreous in the posterior chamber. This would have happened naturally as a result of PVD later on, and the patient would have landed up with a detachment. So you'd have had to keep the patient on a very close follow-up postoperatively to see for retinal tears, but much easier to manage posterior vitreous, especially if you are a VIA surgeon in the same setting itself. Now in this case, again, this is a case of surgical aphakia, and there is some vitreous in the AC, and I was told to put in the lens. And 1 second. Okay, so this is a slightly, again, a little out of the box kind of a thinking, wherein I did do an anterior vitrectomy. I made in 3 ports. I did a triamcinolone staining of the anterior vitreous, tried to push as much of vitreous back into the vitreous cavity.
And again, even lifting.
Okay, by sort of removing those strands that have gone to the wound, lifted the iris skirt as well, and tried to remove every little strand of vitreous. Now this is what I did unusual. Instead of doing 3-port pars plana vitrectomy, I did a 3-port limbal vitrectomy. I made all the 3 ports at the limbus, put in the light pipe. You can actually do this maneuver even under topical anesthesia. Because you're not making pars plana scleral ports, you can get away with even managing posterior dislocation of the lens through limbal ports. So I call this procedure as PPV only, but it's not pars plana vitrectomy, it's called portless posterior vitrectomy, wherein you make all the 3 ports at the limbus and not through the pars plana. And this is the final stage where I put an iris claw lens. Now this iris claw, this is a usual way of implanting an iris claw, but you see the amount of turbulence it creates because there is an open wound and you're going through the main wound. Now this is again an alternative maneuver where you go through the side port with an intravitreal forceps and you enclave one haptic with into the iris, and then you go from the other side port with the same intravitreal forceps, and then you enclave the other optic. So this is another way of probably retrofixating an iris claw lens. This is a very handy lens which is manufactured here by Appasamy in cases when you have surgical aphakia and the iris support is not good to put an iris claw lens. There's a type of a scleral fixated lens where you do not really need to use a suture. You use a foldable lens, you put it into the anterior vitreous, bring the haptic out. These are hydrophilic haptics and they stay very well outside the sclera under the flap without any risk of extrusion or irritation because they are essentially hydrophilic in material as against proline, which we usually use in scleral fixated lenses. So here the hydrophilic material, again the other haptic being brought out through a slit incision which is done exactly perpendicular to the orientation of the haptic, and there you put the haptic under the flap, and that's about it, and you get the surgery done very quickly. So these were some of the unusual cases which I thought I should share with you guys. Thank you for a patient listening.
Thank you, Somil. So it's always such a learning experience for me as well to watch your videos. And anyone has any questions?
That's, it's notorious for making CME, isn't it? Vitreous disruption already there. They're pulling the iris, so conjunctional adaptation. So overall, what will be the CME percentage there?
So the typical CME occurs when the vitreous interacts with the iris tissue, and that causes that irritation. Every strand of the vitreous that you not only find in the anterior chamber needs to be removed, but the vitreous that is even going from behind the iris and sticking onto the posterior surface of the iris also needs to be cleared. So that's why I always lift the iris up and try to remove, like it's like a skirt. You just lift it and you try to remove the posterior vitreous from behind the iris. But I usually don't stop at that. I also go and do a total posterior vitrectomy because I'm not worried that much about the risk of CME. I'm more worried about the risk of peripheral tears and detachment in the late post-operative period. So I do a posterior vitrectomy, and I showed you one maneuver by which it's not necessary to go pars plana. You're doing cataract surgery under topical anesthesia, you can keep that topical anesthesia going on, and you make those limbal ports and you enter through the limbus into the vitreous cavity, and you can do a neat enough posterior vitrectomy there.
Somil, how important is it to do a complete vitrectomy in these cases?
See, wherever you have access, I feel it is an absolute must. If you are a VR surgeon and you are managing such a complication, you definitely have to do it, is what my thinking is. It does not take more than another 7 to 10 minutes to tackle a posterior vitreous, but goes a long way in preventing a huge number of complications later on. But if you are in an anterior segment setup and you are managing a posterior PC rent and you do not have access to a posterior vitrectomy, it's good enough to do an anterior vitrectomy and put the lens in the sulcus, but then refer the patient at least to a VR surgeon on a regular basis so as to see the periphery. In the first 6 months is usually when this PVD occurs and you get this risk of late post-operative tears, and that is when they need to be tackled by a barrage laser or something.
And your advice once a rent happens, what is your advice to anterior segment surgeons? How to go ahead? Should they put a sulcus lens or should they put iris claw lens? I think the most important thing is to clear the anterior chamber from all the vitreous which is there.
Correct. So that is the takeaway point. The lens is an optional thing. You can put a sulcus lens if the sulcus is adequate, and I would advise to always go for a 3-piece lens because it does not cause that retro-iris irritation. But even if you don't have access to a single piece, a 3-piece lens, a single piece lens is good as long as it has very fine haptics and it is hydrophobic in nature, which is usually the kind of lenses that you find. Hydrophilic lenses usually have very stout haptics, and they are the ones that cause a lot of retro-iris irritation, and they cause late onset UGH and things like that. So I would not advise that.
No. So hydrophilic lenses are more UV friendly. So if you at all have to put a sulcus lens in the sulcus, it has to be hydrophilic.
So it's not about the material per se.
No,
when I said it's about the thickness of the haptic.
Thickness of the haptic is more in hydrophobic lenses than hydrophilic. So
the present day hydrophilic lenses that we use, they have that hole in the haptic and they have a double haptic around, like the typical Rayner and the Ultima design that we are talking about.
Less.
Okay.
Thickness
So my
is
experience has been reverse, but point well taken.
And
So
always put a suture.
So Somil,
Yes.
Correct.
Correct.
Under ideal circumstances, it should be a 3-piece. But if you are an anterior segment surgeon and you don't have something handy,
so considering the
Yes,
cases
ideally,
that considering the cases that you had shown, where the first surgeon sent the patient to you, the anterior segment surgeon sent it to you saying that there's sirf lens dalna hai, and you found a nucleus in the back. So would you advise such patients, surgeons to implant an IOL in such a situation, or is better to keep a patient faking and refer them to a retina surgeon?
so it's all about the perception. I would always advise the anterior segment surgeon to put in a lens because he also has to get away clean in terms of an outcome given to the patient. And the patient has this fixation in his mind that lens to dalna hai. So from somewhere, if you put a lens, you manage your surgery successfully. If we have a very dense nucleus like the kind I showed, you can use a fragmentome and you can use a suture, you can do a pars plana vitrectomy, that's all right. But I feel if a lens is put by an anterior segment surgeon, as long as it's a 3-piece lens, it is all right, in my opinion.
So just another question. If a single piece IOL is already placed by an anterior segment surgeon and then in the sulcus, then would you prefer explanting it or would you just...
So very, very good question. I would rather leave it because the work has already been done. If I feel that the patient has a lot of CME and late onset UGH, and I have cleared the vitreous very nicely, then it is only because of the lens, and you'll also see it on the UBM, in which case I'll explant and then exchange it at a later procedure.
Okay.
I won't touch it there and then.
At that point.
Yes.
Usually, if you do a complete vitrectomy, the lens falls back, so there's an adequate
Yes.
gap. It doesn't
Yeah.
retain.
Yes, I've seen that. Yes.
That happens.
That's a very good point actually brought out by sir. It's a hyped thing. It's actually the vitreous that is the culprit, and if you've cleared it really well, even from behind the iris, you usually get away without a UGH.
So with that, we'll move on to the next talk by Dr. Pranav Saluja, who will be talking about cystoid macular edema.
Good morning. At the outset, I would like to thank Dr. Piyush sir and AIOS and all the respected seniors for giving me this opportunity. So I'll be talking about pseudophakic cystoid macular edema. So mainly cystoid macular edema is a retinal thickening at the macula which is associated with cystic changes in the outer plexiform and inner nuclear layers. The overall incidence which has been seen in Indian
The
patients
slides, please.
is usually 2% in uncomplicated surgery and 20% is angiographic CME. The incidence in Indian patients with diabetes has been seen to have 47% without pre-existing diabetic retinopathy and 55% with pre-existing diabetic retinopathy. So the pathogenesis is mainly post-surgical inflammation leads to the release of prostaglandins, and this inhibition of prostaglandin clearance from the aqueous humor by the ciliary processes leads to buildup of prostaglandins. And as prostaglandins accumulate in the anterior chamber, this results in prolonged inflammatory mediator release and breakdown of the blood aqueous barrier. This leads to aqueous flare, and these prostaglandins are then released by the lens epithelial cells, which diffuse into the vitreous and cause inflammation, leading to breakdown of the blood retinal barrier and thus leading to cystoid macular edema. So the risk factors, as we all know, are when a surgery is complicated with a posterior capsular rupture, or there is vitreous humor loss, in cases where there is diabetes or a preoperative diabetic retinopathy is present, if there is untreated elevated intraocular pressure, history of retinal vein occlusion, and a history of epiretinal membrane, and a preoperative or a postoperative use of prostaglandin analogs. So the symptoms are usually unexplained decreased visual acuity after postoperative, usually during 4 to 6 weeks after the surgery, and there is a loss of contrast sensitivity to the patient. On a fundus fluorescein angiography, there is a flower petal appearance of the macula, as we can see, and there is retinal thickening on the OCT, which shows multiple cystic spaces. So what is the natural course? Usually the peak incidence is 6 to 10 weeks after the surgery. 95% of the uncomplicated cases usually spontaneously resolve in 6 months. And the frequency is higher in a poorly controlled post-op inflammation. In a case where there is malpositioned IOLs, diabetics, and again, as we've already talked about, all the risk factors which are present. So how do we manage this case? Mainly once the diagnosis of pseudophakic CME is established, appropriate management usually hinges on identifying an underlying cause. We should carefully examine the patient for IOL malposition if there is a vitreous or iris incarceration, or if there is retained lens fragments. So the treatment usually is a step-ladder approach. We usually start with a topical treatment, and then if the topical is not treated, we can go for an injection. And recently, people have also started using lasers. And if it is not corrected by all of these, then usually a surgery is recommended. So in cases of topicals, usually a topical NSAID may influence the outcomes. There has been a study by Hari Prasad et al. Which found improvement of pseudophakic CME after switching patients which were unresponsive to topical ketorolac and prednisolone to topical nepafenac. And usually topical nepafenac is started, and if it does not resolve, then we can go for a topical steroid, which is usually a difluprednate. Then there are other topicals which have been studied, which is topical interferon, which has been shown to resolve all the refractory CME. And this was given, this was studied elaborately by Narayan Netrale also. Then there are other treatments which are oral carbonic anhydrase inhibitors, and a recent retrospective review had found that this also reduced CMT, although we do not usually use it. Implant steroids are an effective treatment modality, and we can give a periocular steroid injections, which can be either subtenon or suprachoroidal, or an intravitreal Ozurdex or an IVTA also can be given. Although there may be a risk of rise in intraocular pressure and patient compliance, although is better because the treatment is usually for 3 months. So the other injections that we can use is intravitreal Ozurdex. There was a study which was an episodic study which had shown a statistically significant improvement. Intravitreal anti-VEGF have also been tried because they have predicted that anti-VEGF is also released in these cases where there is inflammation. Then these are the medical treatment options which we've already discussed. People have also studied on infliximab and have shown that in cases where there is a refractory pseudophakic CME, we can use an immunomodulator in these cases. So these were other studies which were done on topical interferon and subcutaneous interferon, which found that where CME had persisted for greater than 6 months, it was responsive to interferon in these cases. And people have also used subthreshold micropulse laser, which is a form of laser therapy delivered to the retina in repetitive short pulses. It preserves the retinal pigment epithelium and tickles it, and thus downregulates the apoptotic and inflammatory pathways that lead to a cell damage. Usually we can use a 7x7 grid with confluent shots at a 5% duty cycle. So if nothing works, then surgical intervention may be an alternative treatment, especially in cases where there is a vitreous loss or there is an epiretinal membrane present where the CME is persistent. We can go for a surgical treatment. Lysing these adhesions using vitrectomy may reduce the CME and thus reduce the vitreomacular traction also. So to conclude, topical NSAID and steroids have demonstrated to be effective in chronic macular edema. Topical interferon has been studied and has shown that in refractory CME, it gives very good treatment and reduces the CME. If this does not work, then periocular or intravitreal triamcinolone is also effective. And anti-VEGF is also indicated in some of the cases. Surgery may be done for non-responders to all the medicine. Vitrectomy can be done to relieve the traction, and an IOL exchange can be done if the IOL is irritating the iris. Thank you.
So wonderful presentation, Pranav. So can you tell us more about this topical interferon? I'm quite interested to know more about that.
What is the price where it is available? What is the trade name?
Sir, actually, the price is around 2,000 to 2,500, and I have never tried it, but I've seen Narayan Netralaya people using it, and it has shown that there is a very good improvement in the CME. Usually, it is priced around 1,500 to 2,000 at this point.
How do
you use
give
drops?
it?
No, it is not a drop, sir. We take a injection and then we have to reconstitute it.
But then you give it in the form of drops. Huh?
Yeah.
Okay.
We have to give it in the form. But people have also tried to give it in the form of subcutaneous.
How long do you wait before you go in for an intravitreal intervention with just eye drops in a case of pseudophakic CME?
So usually I wait for 3 to 4 weeks. If it is not resolving, then I usually go for a.
And what is your modality? Do you use NSAIDs a lot or do you use steroids a lot?
I usually use NSAIDs and I use difluprednate if NSAIDs is not responding after 2 weeks. And after 4 weeks, I usually go for an intervention.
Use sometimes multifocal lens, monofocal no problem. Multifocal lens, is there any chance for getting, what is the reason? I think my patient, some of the monofocal no problem. Multifocal, perfectly done in a better and nice way.
More.
In spite of that, 2-3 patients developed CME.
Sir,
What is?
So I think angiographic CME is
different.
practically present in 100% of the patients after a cataract surgery because it's something to do with inflammation. Even if there is low grade, angiographically you may see some leakage. Clinically or OCT wise, you may not see a swelling. Now monofocal lenses, people will not complain if there is a mild swelling. But a multifocal patient will start complaining, and that is when you start discovering it more frequently than what you do in monofocal. That is why probably you are skewed to believing that it happens more in multifocal lenses, but I don't feel it's the case, yes.
So,
Yes, sir.
If the first eye develops CME, what precautions are you going to take in the second eye?
Very good question.
So, precautionary, sir, mostly like what can we do about it, but I'll explain the patient better and do a better patient counseling. And sorry.
Would you start NSAID how many days before surgery?
Usually 2 to 4 weeks before surgery, sir. Even steroids also, people start before 1 week also. And I would just like to see whether the patient is on PG analogs or something like that. Like just to. So if PG and yes, sir, I'll stop the PG analogs for a while for that.
And you start 1 week. It's not necessary to start 3 to 4 weeks before.
Yeah.
1 week is what is propagated that you should start NSAID 1 week. Steroids are is optional. There are a lot of studies which have found that prednisolone is not as effective to control CME in comparison to nepaphenic. So
That's true, sir. We actually have a lot of data which says that preoperative NSAIDs, frankly speaking, has no role. But like you said, these particular cases where you already seen that one eye has developed CME post-surgery, it's like Dr. Somel said that most patients are going to develop it. It's only which patients are going to resolve faster or not. So in those situations, I guess starting NSAIDs at least will give you some peace of mind, if not, correct.
Yes.
How critical during surgery is IOP controlled chamber stability in preventing CME in the other eye if you already got a CME in the first eye?
Yeah,
Would you be more watchful of that maneuvering?
A little bit.
You feel
not
that
sure.
plays a role?
I'm not sure about IOP control, sir.
Vitreous movement.
Stuttering.
yes, too much of wobbling of the antechamber is definitely bad because it causes the whole vitreous to go up and
Correct.
down. That is definitely necessary to maintain it. See, careful. If you have a previous history, then you have to be much more careful in
Careful.
surgery than what you had been in the previous one. Every step has to be very meticulous. And I normally do not use a AC maintainer. But in a high risk case,
But in such a case, yes.
even if I'm doing a phaco, I have a AC maintainer from another bottle
Okay.
in patient who have undergone surgery. in the
Surgery.
previous one.
early.
I firmly believe in what
This
you
is a
just
very,
said.
very important
Yes,
point,
okay.
yes. So maintaining the chamber is probably going to be much more effective as compared to not having a watchful eye on that. What about you, Somil? How often do you operate for non-resolving cystoid macular edema?
So unlike him, like he says 15 days, I would also probably wait a week or so. I'm a little bit more aggressive because as he said, the patient compliance is always better when you go in with an injection, and especially a multifocal lens is so horribly dissatisfied because he's not having 612 vision quantitatively. He's going to be qualitatively so poor even with that 612 vision that he's going to sit on your head. And a shot of Ozurdex probably or an intravitreal steroid, it takes off the edema within 24 hours is what I've seen. So I'm a little bit more aggressive, especially in those kind of patients who have a multifocal lens and have very high expectations. Patients who have a monofocal lens and are willing to wait out a little bit, I will go for a 15-day topical steroid.
So this is 2 weeks of waiting time before you go in and inject a steroid inside. What about vitrectomy? How often do you encounter patients who are not responsive to intravitreal steroids or say anti-VEGFs also?
So the OCT has to show a component of vitromacular traction. That is the only place wherein I will go in with a vitrectomy, not otherwise.
Otherwise, if it is repeated inflammation, especially when you are suspecting a chronic endophthalmitis, which can present as a CME sometimes, wherein the vitreous is slightly turbid, but vision is 612, 618, not improving. You've given enough steroids. Once the steroid effect goes off, there's inflammation
recurrence.
coming up again. So those are the cases wherein you would like to do a vitreous biopsy, do vitrectomy, and see the cause of chronic CME. It could be a very subclinical chronic endophthalmitis, which we are missing probably. We can detect it on PCR and treat accordingly.
Perfect.
I think it's important to wait enough before going for injections. So what I have seen in my practice is patients who are referred for post-operative CME, I wait for 6 weeks. That's my standard regime. Give them NSAIDs and steroid. And most of them resolve in 6 weeks. I've seen, once in a while you do have to inject Ozurdex. But 1 or 2 weeks is, I guess, too early to go in with any kind of injection. For something which can resolve, maybe it's the natural history of the disease that it comes and goes.
Post 6 weeks of recovery. I mean,
Post 6 weeks of surgery, sir.
yeah.
Once I've detected the CME, let's say I've detected CME around 2 weeks time, that's the 10 to 14 days is the time when you yes. Then I wait for 6 weeks. Yes.
There are certain CMEs which appear after a month.
Oh yes, those are dangerous ones. As you
those,
said.
those are little difficult ones.
Yes.
Very true. So again, I'm not as aggressive over here as well. I would personally wait for at least a month before deciding to inject, because most of these patients will resolve. It's not very frequently that you encounter cystoid macular edema now with the smaller incisions that we are making and the faster surgeries and the good equipment that we have. It was seen quite often earlier. So the few number of patients that do develop it, I think it's a good idea to wait it out, and most patients will resolve. Thank you, Pranav.
Thank you so much.
Can I now invite another brilliant surgeon, Dr. Sachin Mauli, to speak on secondary IOLs.
Yeah, very good morning, everyone. Yeah. Very glad to see such a healthy and nice discussion going on in the morning, early morning hours. Thank you, Piyush, for having this IC. Well, aphakia still remains a very common complication of cataract surgery, and it's every entry-segment surgeon's nightmare to leave the patient aphakic. The most common causes are like nucleus drop intraoperatively, or it could be a IOL drop, post-traumatic, or multiple reasons. It could be like weak zonular support, or it could be a it could just be the phimosis of the capsule which causes the dislocation of the IOL in longer runs. So what are the common situations when you, this will be a little overlap with Soumil's presentation, but I'll quickly go through whatever which I can skip. What are the common situations when you anticipate PCR would be during hydro procedures, especially when you are not aware of posterior capsular support, how it is. This is a very typical pupillary snap sign which you are seeing during hydro procedure. You will see the sudden snap in the pupil coming down. So that could be a sign there's a PCR. During nucleus delivery or phagofragmentation is another cause for a PCR. Cortical removal, when you are not very careful about the PC coming in your aspiration port. And it can also happen during IOL implantation when there is a sudden jet or your injector is malfunctioning. Suddenly the haptic goes and hits the PC, and you can have a IOL dislocation. Or it could be some cases PCR can happen wherein you are already ready for such situations. Like this case, there's a PPC, just going with the probe inside, and though the flow was very low, the PPC was very classical. So just when I put on the fluid inside the eye, there's a sudden drop. So these are the cases wherein you definitely anticipate that you want to leave this patient aphakic, or you refer the patient, or if you can manage it. Slides are gone.
Slides, please.
ये लूज हो गया है. उधर नहीं आ रहा है. It's recognized. इसके बाद क्या? Sorry, there's some loose contact. So as an anti-segment surgeon, if there's a PCR, take a moment, recognize what has happened, and assess the PCR. Depending, then later on you can look for the vitreous, remove the vitreous as much as possible. Then look at the support. If the support is good, you can place the lens in sulcus, or you want to refer. If there's a proper drop, then don't try to fish around too much. Try to do a limited vitrectomy, secure the wound, and refer the patient to a nearest retina surgeon. So this is a case wherein it was referred to me. Patient had a drop nucleus, and I could see some sort of support there. Entricapsular support was there. So I'm doing an intravitrectomy in this case, trying to remove all the nuclear material inside. There's a large nuclear chunk which is there along with the cortex. So I'll just run through this video. So these are this is a very hard nucleus. I have stopped using fragmentome in very hard nucleus. What I prefer doing is bringing it in the antechamber. Anyway, we have made a section to deliver it through the SICS like a tunnel wherein you push through the so the nucleus is already smaller because you have already removed a lot of cortex. You don't have to make a very big opening. So with the infusion on with a nice visco delivery, this nucleus can be delivered very easily. So and then once the nucleus is delivered, you assess the support properly, whether the support is good and if there are any vitreous strands around. And if you see any vitreous strands, use a cutter to cut these. And the support was good in this case, wherein I decided to put a single piece lens in the sulcus. So these cases really do very well. I mean, you don't have to have too many fancy gadgets. It's a very simple technique wherein always after putting the lens again check for the vitreous strands. So when you have this is about the dropped nucleus and aphakia management. When you have dropped IOLs, we have many options wherein looking at the support of the bag, what stage and where you want to put the lens. We could even place the lens in the bag if the PCR is very small, and you can also think of ACOL, which we rarely use it nowadays. Iris claw, iris suture lenses, sulcus fixated IOL, scleral fixated. There are various type of scleral fixated IOL. People have started advocating sutured, glued, sutureless, Yamane techniques. All these are the options. Very good ACIOL, doing a very good, I mean, you need to have a lot of experience to place an ACIOL because this is associated with a lot of complication, including corneal decompensation, IOL haptic being stuck in the, your main section and causing endophthalmitis, secondary glaucoma. All these things are very, very commonly associated with ACIOL. Iris claw lenses, as already Somil shown the video and discussed with this, it's associated with a lot of inflammation. A lot of my patients started complaining of a shaky image because of pseudophygodinosis. So I've stopped using this type of unless I don't have a IOL option in my OT on that day, only then I use this. Otherwise, I've stopped using this. So this is the safest option. If you have a good sulcus, if you have a good support of an enterocapsule, then the best option would be to place a 3-piece IOL in the sulcus or a rigid IOL in the sulcus. You'll be safe, and this is the best option, I feel, because all these patients really do well and they look very good post-operatively, and you can achieve a good visual recovery. So like this case, this was an IOL drop case wherein you can see a very good support there. So what I did was removed the IOL. I don't fix any foldable IOL nowadays in the sulcus. It's not advisable because it creates a lot of inflammation and iris chafing later on. So always prefer a 3-piece lens or a rigid lens. So do a thorough vitrectomy, pick the IOL, bring it in the antechamber, deliver it out, and then you can place a rigid IOL in the sulcus. Scleral fixation of IOLs, most commonly which we use are glued IOLs or suture technique, wherein we have multiple points of sutures which we take and we create a tunnel at 3 and 6 o'clock and then fix the IOL there. There are various sutureless techniques also. This is a case in which there was a dropped nucleus, also a dropped IOL. You can see both the nucleus and the IOL both have dropped. The anterior segment surgeon had tried to place a lens after the drop which he noted. Unfortunately, he couldn't do both of that. So a thorough vitrectomy was done, the nucleus was removed and managed, the IOL was explanted. So there was absolutely no support, even though this was a rigid lens, there was absolutely no support of the capsule anyways. So I had to bring it out in the anterior chamber, explant it, and then do a scleral fixated IOL. You can see already I've made a scleral flap there, and I'm going to take these sutures. In my hands, I always prefer doing sutured SFIL. I've tried blue diols. I've tried multiple types of Yamane technique, wherein I'll show the video of that also. But in my hands, this is done very well, and this stays long. And long-term results of this type of sutured IOL are very good because the sutures don't give away, and they are under the tunnel, very safe. So once you take the suture, you tie it, titrate, and then you're done with it. So this is a case in which I did Yamane's technique. Absolutely simple procedure, not much of suture related issues, wherein you make a tunnel enough for a 3-piece IOL to go inside and a side port. So this was a dislocated IOL with the bag, and IOL was cut and removed to the small tunnel. So once the IOL is removed, what I'm doing is I'm just going to place a 3-piece IOL there in the anterior chamber and try to manage the haptics. So around 2 millimeters from the limbus, take a 30 gauge needle, go inside, and then engage your haptic in the needle, like showed in the video now. And once you engage it, bring it out directly, transconjunctivally. So one side you bring it out and keep it there. You don't remove the needle. Keep the needle there. Go through the other end, and then engage the other haptic in a similar way. Because if you release this side, then the IOL might drop. So be careful. This is the only tricky situation in these cases. I'll finish. I just have one slide after this. So once you externalize the haptic, you can use a cautery to the tip of these haptics, wherein you create a bulb-like thing there so that it stays, and you push it under the conjunctiva so that post-op exposure of these haptics doesn't happen. So this is what you have to do. This is very meticulous so that the haptic is under the conjunctiva and it's not exposed. So this is a very simple technique, very easy. You can get away, with a lot of cases easily. So what are the factors influencing the visual outcome are, we should always be careful about the cornea related issues, glaucoma related issues, vitreous traction, any sort of vitreous traction you are leaving behind can lead to a lot of complications like a HST or a CME or various things. Retina and choroid related problems, in most of these cases, sudden hypotony due to either dislocated IOL or a dropped nucleus can cause choroidal detachment. There could be retinal detachment. A thorough assessment is required before you take up these cases. Thank you so much.
Thank you, Dr. Sachin, for this a lovely bouquet of surgical videos. So it's a very nice thing to be aware of all the types of implants that can be possible. I think we've covered almost all implants. One implant that was shown by that was missing in Dr. Sachin's talk was also shown by Saumil, the upper CMT flex lens. So of course, so two important points that I would like to mention is that one is it's not necessary to have a pre-decided set notion of which implant to go in for. You always assess on table what kind of implant would be best for the patient. If you have capsular support, it is still the best to put a 3-piece lens in that situation. So any questions from the audience?
No, a lot of patients, I've done more than 200-300 patients. I did analyze all those patients. More than 60% of them complained recurrent redness after you stop the steroid. One. Second was there was very unusual symptom of a shaky vision. They couldn't focus, especially for the distance, not for the near. Especially while driving and all, they feel the vision is little shaky. I mean, it's pretty common. I've discussed with this, though it's not published anywhere, but it's pretty common with a lot of retina surgeons who are doing this. So these are the 2 points which have stopped me using these lenses very commonly. Though it's very quick, and I still use it if I don't have a library of the lens or odd power lens wherein I cannot put anything and I have to manage the case on table. Sometimes I do. It's a decent lens, but these were the 2 points. When it's a planned surgery, I would like to do a sutured SFIL or a sulcus fixation. Depends on the availability.
No, sulcus fixation definitely. If you have a sulcus, there is no other way. I mean, sulcus fixation would be number one. But when you don't have any capsular support,
Then suture IOL is my preferred choice because I feel it's most safest, most scientific. Because all these Yamanes and all, you are leaving scope for exposure, and there's a track which you are leaving, which goes directly into the vitreous. And I've seen a lot of cases coming in a late endophthalmitis because of the haptic which is exposed. All these things are there. Glued IOL is my second choice after suture. Not that because glued IOL again also it goes in the tunnel and you have a good coverage. So covering these haptics or the sutures with the flaps, scleral flap and a conjunctiva on top is the safest option for me.
you haven't done CMT flexes because
No, I have not used them. I have not used them.
How easy to use the CMT flex lens? Because looking at the lens, it looks so flimsy that haptic. You're worried that it may
yeah,
break.
so it does. If you yank it a little bit less gently than usual, then at that T-shaped junction, the connection, it has broken in a couple of cases.
So just not just yanking, even
What
if you
are
just
the
grip it
export-
hard,
Yes.
it can still break. So I've had
So the only place to grip it is absolutely at the intersection of the T. If you can hold it there very properly, you can exteriorize also well, and it will not have that much of an incidence of breakage.
So you do a lot of iris claws. Have you faced something similar to what he described?
He's absolutely correct in what he said. The first point I don't agree with. He says more inflammation with iris claw, more redness and all. It's the same with scleral fixated. In fact, scleral fixated has more interference with the ciliary body. You've created a tract. There's more extrusion chance with the proline haptic, especially if you've done Yamanes or something. And even sutures sometimes, if your scleral flap is not very healthy, I think that redness component I wouldn't agree. But yes, the movement, yes, a lot of patients do complain about shaky movements. But more worried than the symptom of the movement, I'm worried about the fact that they have a phenomenon called ophthalmodonesis. If you've not cleared the vitreous nicely, you've just done an anterior vitrectomy, that ophthalmodonesis or the movement of the vitreous and the PVD induced therein will cause late secondary tear formation and detachment. So if you've done a good posterior vitrectomy, I mean iris claw is always hand in hand with a good posterior vitrectomy cleanup, having induced PVD and everything.
Yeah. So in my all cases, I do a complete vitrectomy. I don't do an intravitrectomy at all. So all the cases whichever I take to put a secondary IOL, it's complete vitrectomy, including PVD induction.
So there ophthalmodonesis will not be a problem, but yes, the
Shaky vision
is going to be a symptom in a few cases.
Yes.
I really feel the iris claw should be made 4-point fixation or 3-point fixation. If that is done, that shakiness will be avoided to quite an extent.
One of my retina doctor says that at times when you impale, if you impale little closer to the pupil, then there is a more chance of
Yes.
So you have
Yes.
to go as far peripheral
It's
possible.
2/3, 1/3 junction. 2/3 from the pupillary border, 1/3 from the limbus. Yes. You won't even get a cat's eye pupil as a result of this. So very, very good, valid point.
So we'll, okay, one quick comment and then we'll move on.
Yeah. Most of the claw lenses you have here have relatively rigid, rigid material. So how do you make sure that you don't, damage the claw while trying to enclave it? Because that can lead to late dislocation. Sometimes when you're enclaving
The claw doesn't get damaged.
So you can know it doesn't, if it breaks, it will not.
No, sometimes it doesn't break completely. What happens is it just gets a little fracture at one point. It's still holding, but sometime later it
Sir,
releases.
there is a good video by Dr. Haldipurkar. He's a good friend. So he uses an external light from the side to know, and he can very beautifully see the clamp if the light source is from side, not this. The microscope light is off. The VR light, endo illuminator is from the side, and that illuminates. Yes, transilluminates. That looks very nice. You can clearly see the.
So he can transilluminate the actual
limbus, from the limbus.
the lens itself.
Yeah, from the limbus you put the light and hold the lens and tuck. Your assistant holds the light.
Tucking is not the issue. You've tucked it. Now what happens is in the process of tucking it, you got a micro fracture at that junction. And your tucking is fine. You can see the tuck quite well. And
Very valid and difficult to manage such cases wherein, like what he says, if it breaks or fractures during tucking, because one side you've already done and the other side. Explanting these IOLs will
Very
become very
difficult.
messy because
Very
you
messy.
need to use scissor, cut the iris, and it becomes too traumatic for the cases.
No, sometimes what happens is you can see a good tuck. It's just there's a micro fracture further on which ultimately releases that tuck.
But preferably you should explant it, sir, and then put a different.
That will be happen. That will happen. That will happen some
later
days
on.
later.
Later on.
How do you know it?
You'll not know it unless.
So that is one of the reasons he's not doing iris claws, because he doesn't like him. It's, like he said, it's extremely messy to remove it once it's enclaved well. We can actually have a talk about that later. We're going to move on to the next talk right now. So the next talk is by my dear friend Dr. Rajiv Jain, who's going to be speaking to us about endophthalmitis.
Very good morning to everyone. Can we have the slides on, please? Yes. So management of endophthalmitis revolves around intense medical treatment and surgical intervention with salvaging the eye and vision being the primary goal. So what are the symptoms? If a patient in first few weeks of surgery comes with blurred vision, pain, photophobia, swollen eyelids, redness in the eye, discharge, floaters, and sometimes fevers, then that should warn us about the endophthalmitis happening in that patient. What is our clinical approach? Thorough history taking is important, and it's very important to have the blood sugars of the patients controlled. But because we have seen that in endophthalmitis patients, if the blood sugars are not under control, the management becomes very difficult. And the symptoms you look for, the examination you look for, you start with the routine examination like initial visual acuity, which gives us some idea of the prognosis, which you can explain to the patient. You look for orbital inflammation, you look for eyelid, conjunctiva, cornea, anterior chamber, lens, vitreous, fundus. It's important to have a good look at the fundus because it may further help you in management, taking the decision about the management. This is what you see: intense marked anterior chamber inflammation, membranes, hypopyon. It's important. It's always important to look at the wound site because there might be a leak at the wound, and wound infiltrate as well. Exudates all over the IOL, hypopyon, and here you can see there is a bleb infection as well. So once you see hypopyon, you see bleb infection, you see vitreous exudation, then you are sure that this is endophthalmitis. But cases who present early with inflammation, there is always a doubt in the mind which entity is this, whether this is endophthalmitis, whether this is TAS, or it is lens-induced uveitis because of retained lens fragment in the anterior chamber, some fluffy matter in the anterior chamber. So with good clinical history and examination, you can actually rule out. But whenever in doubt, between post-operative inflammation and endophthalmitis with severe haze in the ocular media, it's always give benefit of doubt and make diagnosis of endophthalmitis and proceed accordingly. So what a routine case. So our clinical management nowadays is not based on whether the presenting vision is light perception or better, because what EVS has told us was that if the vision is light perception or worse, then you go for vitrectomy, otherwise you go for injections. But nowadays with improved surgical maneuvering and instrumentation, we go in for vitreous surgery quite early. So you take AC tap and vitreous tap and you send it for gram staining and culture. And another thing which I want to point out is nowadays we send a lot of these patients for exciton as well. And the positivity rate in exciton is PCR analysis, and they have different panels of acute endophthalmitis, chronic endophthalmitis, even for uveitis panel is there, where I found out that the results are very good. And most of the cases you find some organism and which help you in further management also. Ultrasound is, it helps. It's not mandatory, but we do it in all the cases to look for membranes, opacities, and whether the retina is attached or not, how is the choroid, and if you have to plan surgeries, then you have to plan your reports, whether the detachment is there or not, so that you can prognosticate the patient also. So the treatment protocol, the goals of the treatment in these cases is you want to retain useful vision, minimize the infection with antibiotics, limit the inflammation, and give patients some symptomatic relief. As I said, our choice of treatment is determined by the clinical picture and not whether the vision is light perception or worse. So we choose intravitreal injections if we can see retinal details. The red glow is very good, and that is the time we give go ahead with intravitreal injections. But if the retinal details are not seen, there is a poor reflex, and if after 24 hours after initial injection there is no improvement, most of the times we go for vitrectomy. And as I said, medical management along with the injections is the mainstay to start with. We give intravitreal antibiotics. Along with it, we give periocular, topical, and systemic antibiotics. We give steroids, topical steroids, systemic steroids if the patient is non-diabetic, and we have ruled out fungal endophthalmitis along with cycloplegics. So why intravitreal antibiotics? Because all of us know that there is poor penetration to topical and systemic antibiotics in the vitreous, and so this is a slide which is, I think, one of the most important slide nowadays. Is we all know that for gram-positive, vancomycin works in most of the cases, and till now most of us were using ceftazidime as first line from gram-negative. I don't know what the panelists use, but I have shifted totally to tazobactam plus piperacillin or imipenem for gram-negative. And there is a study going at LVPI. Dr. Das had presented recently with Dr. Savitri that in our subcontinent it's always better to start with tazobactam plus piperacillin or imipenem rather than restrict yourself to ceftazidime, and the results are better with second line antibiotics for gram negative. In fact, this has become first line for us nowadays. So as I said, medical therapy is intravitreal injections along with the oral antibiotics and steroids, and you use adjunct therapy along with it. Steroids are very important. Once you have ruled out that it is not a fungal endophthalmitis, steroids help in reducing the inflammation, and the symptomatic improvement is there. As I said before the EVS, there was widely divergent opinions regarding timing of vitrectomy and when to do it. They found out that there was no difference in visual outcomes whether or not an immediate pars plana vitrectomy was done if the vision was light perception or worse or better. So they concluded that you have to do vitrectomy only if the patient presents with vision of light perception or worse. However, this study was conducted in 80s and 90s. At that time, our surgical skills were not that good. The instrumentation was not that good. So nowadays, as I said, our management depends on the clinical picture and the course of the disease. And why vitrectomy? Because it gives us early sample for vitreous culture to start the specific therapy. It clears the ocular media so that you can assess and see the retina and manage accordingly. It facilitates better diffusion and penetration of antibiotics into the vitreous cavity, and it removes the inflammatory debris. So mind you, it's not the bacteria which is causing the damage to the retina and optic nerve and blood vessels. It's the toxins and the products which are there. If you have removed them to a large extent, you have stopped the ongoing damage. The only thing remains is to control the infection. So the surgical technique includes, I have time. Surgical technique includes putting us infusion cannula. We prefer longer cannula. Earlier times when we were using 20 gauge vitrectomies, we used to have 6 millimeter cannula. Now with 23 and 25, the trocar cannula already they're long enough so that most of the cases you are able to visualize it through the second port. And another important thing is to have a good cutter and sharp trocar and cannula set. See, what happens is endophthalmitis case, they are referred by our colleagues, and we are supposed to operate these cases at lesser cost. But these are the cases where you need good cutters and new instruments, because once you are putting a trocar on cannula, you are causing traction to the peripheral vitreous. If the trocar and cannula are not sharp enough, you can actually cause peripheral breaks, which is a devastating complication in a case of endophthalmitis. So what I do is I use I charge more for my endophthalmitis cases from my colleagues who refer these patients to me. And I use these instruments only twice. Once I've used it, we ETO it, and I use it once more, then I discard it. So vitreous biopsy is important step, where what we do is so we attach syringe to the aspiration port of the cutter. Cutter has got a as you can see, we have attached syringe to the aspiration port of the cutter, and with the no active aspiration, we go inside the eye. We can see the tip of the cutter. We start cutting at high cut rate, and slowly move from behind the IOL towards the core of the cavity, and then gently aspirate the material which has come into the cutter, and we take out this retractor outside, and whatever fluid is there in the tube, we take it in the syringe, and then we start the infusion after this step only. And after starting the infusion and after completing the vitrectomy, we send the cassette sample also for microbiology and staining. I think if a lot of membranes in most of the cases are there, and what we do is it's important to remove the membranes to have a good view before doing the vitrectomy. You enter through the anterior chamber. If the epithelium is edematous, don't be afraid of removing the epithelium. You can scrape it off. And these membranes. I was thinking of bringing it to the so that I can show some steps of removing the membrane. Anyways. So you can go with Simcoe, remove the exudates in the anterior chamber, remove all the membranes so that you can have a good view of the posterior cavity. So pars plana vitrectomy for endophthalmitis has conventionally been taught to be a core vitrectomy. Because of increased retinal fragility and edema, there is always that risk of retinal breaks forming during vitrectomy. However, what we have seen is that retina is not that fragile. It's more fragile, more chances of creating breaks in the periphery, but the posterior pole is more or less intact, and you can actually go down. Don't have to induce the PVD in these cases, but you can go and see the details and come out. IOL explantation is not necessary in all cases. We try to preserve IOL as far as possible. However, in fungal and P. acnes endophthalmitis, these are the cases where you may have to remove the bag along with the IOL. And role of intraocular tamponade like silicone oil is controversial. It has no place in routine endophthalmitis surgery. However, if you encounter a retinal break or a detachment, then it is must. The advantage is it gives you a long-term tamponade. Your media is clear. You can visualize the retina. You can visualize the progress happening. And it is also said that it is a bacteriostatic tamponade. So the growth of bacteria is also hampered. These are so to conclude, our choice of treatment is determined by the clinical picture and course note, whether the vision is light perception or worse. And our goal is to do a safe and maximum vitrectomy as much as possible. Intervention early than late means whenever you have doubt, tilt your diagnosis towards infectious endophthalmitis and start the treatment. And complete rather than partial vitrectomy is reasonably expected to offer prevention of further retinal damage, irrespective of visual acuity. Thank you.
Thank you, sir, for this lucid and very all-encompassing presentation. You pretty much covered everything, but we won't take any questions over here. We'll move on to the next talk. So most of the important talks have already concluded. Mine is just going to be an addition where I'll just show a couple of case scenarios, my own experiences, and what I've learned from my colleagues, one of them sitting over here himself. So we'll just move on to the next talk then.
While he's setting up his presentation, maybe we can take a quick question. Anyone? Yes.
By and large, it's accepted that oral antibiotics don't have too much of a role and you got to use intravitreal. But does anybody have any thoughts on using oral linezolid in those low-grade infections that you get, say, after 5 days?
So we do use in most of the cases. So oral, either ciprofloxacin or linezolid, we use it routinely.
But will it work alone?
It won't work alone, sir. Never.
And what about some drugs like Claribid for P. acne, clarithromycin?
So after
Orally.
vitrectomy,
As an adjunct
after vitrectomy, yes, people give it for 4 to 6 weeks also.
also. And does it seem to make a big difference or not?
So I'm not sure, because most of the cases we do vitrectomy, and these cases they still keep on recurring,
Okay.
whether you use Claribid for 4 to 6 weeks or not.
Medicinal procedures may be required at a later date.
So these patients, yes, there is a very high chances of these patients developing epiretinal membranes. So this is one, and if we have done, what we do during the surgery is we make a capsulotomy with the cutter as well, because the capsule opacifies very quickly in these cases. This is what we have seen, and mostly it's the ERM related, sir.
Done? So very good morning, everyone, and thank you for everyone to be over here on a Sunday morning. So I'll be talking about a few tricks that anterior segment surgeons can perhaps use in case if they land up in soup. Tricks that perhaps are more, they come more naturally to a VR surgeon. So just an irony, so when you're catching small fish in calm waters, it's pretty easy, but so is operating a straightforward cataract. But it's essentially catching these big fish with the same technique out in the ocean that is not always yield a good catch, and similar to that in cataract. So, but what if the instruments that are used in deep sea fishing are applied to surface fishing? And as we all know, vitreoretinal surgeons are expert divers in troubled waters. We have ultra sharp, ultra small instruments. So a change in strategy and instruments in difficult situations, it does hold promise of good results. So similarly, we'll go through a few scenarios. A traumatic cataract with a fibrosed anterior capsule, as you can see over, it's extremely difficult to even make an opening and then extend the rhexis. So again, using a retina forceps over here, an end grasping forceps over here, using a retinal scissor over here to make multiple cuts and then grasping it repeatedly to make sure that you have some sort of a capsular rhexis that you can make over here. Sometimes the end grasping forceps gives you a better grip as compared to even a micro rhexis forceps. Similarly, another case where you're making a rhexis and then it extends. So again, in such a situation, I personally like to use an end grasping forceps. Of course, you need to use a combination of different forceps and instruments so as to give an optimal outcome. As you can see over here, now it's extended, and then gripping it and then pulling it back. And you have a good rhexis that you can proceed with with phaco. So another similar case, I'm going to skip this now because we've quite overshot time, because it's essentially the same. Now, many a times you have these traumatic cases where you've got fibrotic membrane stuck to the cornea, and again, removing them can be a challenge sometimes. So again, using two instruments, micro instruments that we use as retina surgeons, like you see over here, a forceps and a scissor, and then using it bimanually and grasping onto the fibrotic membranes with your end grasping forceps and using a scissor to begin cutting these membranes. It makes it easier for us to remove them. Corneal opacity cataracts again can be challenging sometimes, and of course, transillumination that we all spoke about earlier has been the way that additional visualization was given, wherein you're using endo illumination from the outside, where your assistant is holding it. Another way is using a chandelier illumination, which essentially gives you an actual retro illumination, as you can see over here. So you see, it's going to be a difficult scenario. So putting in a chandelier illumination, a 25 gauge chandelier illumination over here, gives you a good retro illumination. You can switch off the microscope light, and it gives you additional clarity. As you can see, it's easier to remove those phaco pieces, less chances of complications that can happen. And whenever you want, you can obviously switch on the light, as you can see in the next case. I need to thank my dear friend, Dr. Somil, for this beautiful surgical video. So again putting it on, putting in a chandelier illumination, and then you can see how nicely, you can visualize your rexis at any particular point of time. You can switch on and switch off between your microscope and your illumination. It's especially tricky in the area where you have those corneal opacities. And after that is done, again, the steps are going to remain the same. It's essentially just a matter of better visualization. So now the illumination has been switched off. And again, there's slight confusion about the phaco over here. And then you switch on the illumination, and that gives you good visualization. And once this is done, most of the difficult part is over, and then you can implant the IOL. Now, you have these small eyeballs many times that, there's a very big, there's a huge buildup of posterior vitreous pressure, and the space to operate in the anterior chamber is quite less. So in such situations, one good technique that I again learned from Saumil is, again, it's a small pupil as well over here. So after putting in iris hooks to increase your field of view, what we do over here is put in a 23 gauge, 25 gauge, or 27 rather, a sclerotomy port, do a little bit of core vitrectomy that bulks the vitreous, central vitreous, and brings down the pressure temporarily. You can put the plug back, or use a valve cannula, and then go ahead and operate like a routine phacoemulsification. Obviously, you have to be a little careful because there can be sudden buildup of pressure, and anytime there is a buildup, you can do a little bit of core vitrectomy and reduce the posterior vitreous pressure. Chances of complications are comparatively, I'm sure everybody has encountered situations like these, wherein you, if you anticipate it, you can use mannitol and you can use Dimox, but on table, if this happens, this is a good way to counter that problem. As you can see, there was a little bit of pressure build-up again, a little bit of vitrectomy that was done, and after the lens is out, putting the IOL in. And then one can remove this sclerotomy port. So there was a lot of discussion on iris claws. So this is another technique I learned. I've not done too many of these, but instead of putting it, holding the iris claw with the iris claw forceps and then holding it and then enclaving it on either side, another technique that Saumil came up with was pushing it in and then keep moving the lens in the position that it has to be fixated, and then going in from the side port, holding the haptic, and then using your second instrument to enclave it, and then repeating the same procedure on the other side. That kind of reduces the pressure that you put on the globe. So there are these cases of capsular phimosis that you end up with. So using a retinal scissors sometimes can be quite easy over here to make multiple cuts and then use your vitrectomy too. Now, of course, you have these posterior chamber plaques sometimes after you put in an IOL, and most of the times you end up using a cutter to eat away the plaque. What you can also do is use an MVR, slightly bent MVR, and try to scrape off the plaque. In case if it, most of the times you're able to remove it. In case if there is a complication, you always have the cutter to remove the central, the posterior capsule. So the take home over here is essentially that, just like Dr. Saumil had shown, there are multiple ways of bringing the nucleus out or removing it inside. You have multiple ways of tackling these problems that you commonly encounter, and simple techniques and simple modifications can offer solutions to all of these. So thank you very much. So if there are no questions, we are almost just managed to finish in time. So thank you very much for being over here. If we can have a group picture.
Have the people for the next line of talks have already come?
We are giving the hall to them.
Yeah,
2 minutes before time. So. I don't know. Ours is finishing at 9:30.
last submit. पीछे का ठीक आ रहा है?